Hello everyone, welcome to the continuation of instrument classes, and today we shall discuss on laryngoscope in detail. Starting with laryngoscope, this instrument is laryngoscope. So laryngoscope is an instrument which is used to examine larynx, that is the voice box, vocal cords and the surrounding structures. It is also used to help insert ET tube during intubation. So these are the different sizes of the laryngoscope blade. The types of laryngoscope, there are three types. Number one, direct laryngoscopy, which one is having the handle and blade. The picture you saw in the previous two slides are the direct laryngoscopes. Then indirect laryngoscope, it uses mirror or fiber optics in the blade. And third one is the video laryngoscope. This one has camera at the tip of the blade which displays the airway on the screen, so you can see your parts on the screen. So these are the three types, but we'll be discussing mainly about the direct laryngoscope. Other types are more used in the ENT department. Let's start with the parts. So number one, this part is known as handle. Then comes number two, that is this one. This is known as blade. This blade can be straight or it can be curved also. Then comes the number three part, this one. This is known as slip groove. So where the blade attaches to the handle. Then comes number four. This is number four part. This is the light source. Once the blade is attached to the handle this way, this gives the light, or it is like a switch. Then comes the number five, this one is the bulb. So when this is attached, this bulb is lighted, also known as light pipe or the bulb. It is elongated like this. So through this light you can visualize the vocal cord. Okay, now the blade types. So we said there are straight, blade can be straight, blade can be curved like this. Straight blade is known as Miller blade. This is usually used in the younger children, infants, as the larynx in the infants is situated more anteriorly, so you have to use a straight blade. And whereas beyond infancy until the adult age, you use curved blade. Curved blade is known as Macintosh blade. So the parts are same. Now come to the different blade sizes. So there are different sizes like this. So extreme preterm babies, you use blade 00, and 10 blade is used for preterm babies, and blade number 1 for the term babies, blade number 2 for 2 to 10-year-old children, and blade number 3 for children more than 10-year-old. So 0, 0, 0, 1, 2 and 3 this way. So these are the different shape and sizes of the laryngoscope blade, and whereas all those they fit in the same handle this way. So in the handle, inside the handle, here you can open this and then you use batteries. Now indication of using laryngoscope. There can be therapeutic, there can be diagnostic use. So therapeutic use is number one, to introduce the endotracheal tube, and the detailed conditions indication we'll talk later with the ET tube. Number two, suction of the larynx, pharynx under direct visualization. Number three, while giving general anesthesia. Now come to diagnostic indications. Number one, to visualize laryngeal web. Then to visualize the vocal cord. Vocal cord palsy can be diagnosed by using the laryngoscope. To see for the stenosis, foreign body inhalation, and the diphtheria patch on the throat. And then while taking biopsy material, you can use the laryngoscope, or you should use the laryngoscope. Then contraindication, if the local area is very friable, so usually when the child comes with a corrosive poisoning like a acid alkali poisoning, you should not use. And then epiglottitis and croup, you have to be very careful. Unless very severe, you should not use the laryngoscope, because there might be sudden laryngospasm which leads to cardiopulmonary arrest, and then even death can occur. So you have to be very careful in cases of epiglottitis and croup. So actually it is contraindicated. Try as far as possible not to use laryngoscope or intubate. And then third is, if there is a local trauma in the neck, the area, the throat area, then also it is contraindicated. Now technique of intubation, or technique of using the laryngoscope and then putting the tube. For this, number one, you start with the preparation. Here, place the baby supine like this. Place a pillow under head and neck like the one you see in the picture, and not under the shoulder, so that head is not too extended and neck is not too flexed. So this position is known as neutral position or sniffing position. So this position allows a straight line of vision from mouth to vocal cord. And then while intubating or putting the laryngoscope, always examiner should be standing at the head end of the patient. So this is the patient, this is the head. So at the head end, the examiner should be standing this way. So again, let's see the position. This is the correct position, which is showing line of sight is very clear. Here this is incorrect position, because this is hyperextended, and this is also incorrect, this is flexed. So when you do this at these two positions, the sight of vision is obstructed, it is not clear. Then number 3, insertion of the laryngoscope. Always hold the laryngoscope with the left hand. Whether you are right-handed or left-handed, you have to hold the laryngoscope with the left hand, because the blade is facing towards the left like this. And introduce the blade from the right side of the mouth, right angle of the mouth you should introduce, sweeping the tongue to the left side. Then gradually you advance the laryngoscope until you reach the tip of the laryngoscope reaches the base of the epiglottis, which is known as valvula. So this valvula is sitting over the glottis. Glottis is the opening of the larynx. So until you reach the base of the epiglottis, you should advance the tip of the blade. So after reaching the valvula, base of the epiglottis, then you lift the handle up and forward like this, up and forward, which flips the epiglottis upwards. So when the epiglottis is flipped upwards, then it exposes the glottis. So glottis, that is the opening of the larynx. So this opening is seen where you can see two white vocal cords. So these two are the white vocal cords. In a triangular structure, you can see this line and this opening. So in this opening, you are supposed to introduce the ET tube. So again, showing you the same insertion of the larynx. Initially introducing the larynx, holding with the left hand, then gradually you are proceeding forward till the tip of the blade reaches the valvula. Then you lift the laryngoscope upwards and forwards to expose the vocal cord. So many times you give a cricoid pressure like this with a little finger. So if you give a cricoid pressure, you are blocking the esophageal passage. So when you do that, chances of mislodgement of the ET tube is less. The ET tube goes through the trachea only, it will not go to the esophagus. So many times you can even give a cricoid pressure like this. either with your little finger or someone can help you, and then give a pressure like this. Then after that you have to put the ET tube. So before the tube placement, it's good to suction the mouth like this. So when the secretions are all taken out, suctioned out, then the vision is very clear. So after that you insert the endotracheal tube through the vocal cord. So ET tube I'll be describing after this. Then advance the tube until cuff is 2 to 3 centimeter beyond the cords, and then you secure at this level and then inflate the cuff. Then fix the tube with the using adhesive tapes at the angle of the mouth. Now after putting the tube, you have to confirm the placement of the tube, whether you have placed the tube in the correct position or not, that you have to see. So to see that, there are various points you can see. So these are the 7 points you can see. Number 1 is bilateral chest rise. So after putting the tube, when you are bagging, you can see the chest rise. Bilaterally the chest should be rising. Number 2, saturation of the oxygen should increase. Saturation should become better. Another, you can see fogging in the tube because of the expired air. Number 4, no gastric content should be refluxing out in the tube, because sometimes when you intubate, the tube goes to the esophagus. So if the tube goes to the esophagus, you can see the gastric content refluxing out. So that should not occur. Number 5, equal air entry to both sides when you auscultate. So after putting the tube, you should bag and then auscultate bilaterally and see, so you can hear the equal air entry. So next is by X-ray you can do. So in the X-ray, tip should lie between the thoracic vertebra T2 to T4, that is just around approximate 2 centimeter above the carina. The T2 to T4 is equivalent to 2 centimeter above the carina. So in the X-ray you should be visualizing that. But out of all these, gold standard will be using N-tidal carbon dioxide detector, that is also known as EtCO2 detector. So this is actually a monitoring device which is used to measure concentration of the carbon dioxide in exhaled air at the end of expiration. So this will be the best. Now complications. What complications can arise with a laryngoscope? So you might break the bulb and there is aspiration of the bulb while intubating. Sometimes the bulb is very loosely fit, the fitting is not tight, so you have to always check that. So if the screw is not properly tightened, then there might be, the bulb might fall and then patient might aspirate. There might be dental injuries, mostly in the upper incisor, especially when the intubation is being done by the inexperienced hand. And another is damage to the soft tissue and nerves. If you are not delicate, then the injury might occur. Then injury to cervical spinal cord if the procedure or maneuver is aggressive. And there might be hemodynamic alteration like tachycardia, hypertension or arrhythmias can occur. Okay, thank you. So next class I'll talk on the remaining instruments. Thank you.